Hello and welcome to our educational webinar to discuss topical photodynamic therapy. The webinar is being presented by our guest speaker, Paula Oliver, a dermatology nurse with a speciality in skin cancer and photodynamic therapy. Paula led the UK nursing team for Galderma, delivering education to healthcare professionals in general dermatology. With extensive knowledge and hands-on experience of the PDT treatment, Paula is now an independent consultant focusing on education and clinical care in the field of dermatology. So Paula's going to talk through the presentation and then we'll answer a series of questions at the end of this session. Thank you, and over to you, Paula.
Oh, thank you, Louise. I'm really delighted to be given the opportunity to do this session for you today, and I hope your customers will find it of interest. So, as you said, Louise, I've been in dermatology for quite a few years, more than I care to mention, and have really particularly focused in photodynamic therapy over the last 22 years. So we're going to take you through what is PDT and give you hopefully lots of information that you can consider for future clinics that you might develop. So just a disclaimer, as Louise alluded to, I have worked for Galderma over the years. Currently, I'm actually in an independent consultancy role, and I'm actually working with the Biofrontiera team that actually do have a photosensitizer on the market for PDT. So without further ado, we'll get going. So we're going to look at what photodynamic therapy is, and we're talking about topical photodynamic therapy rather than systemic form. We'll look at the photosensitizer prodrugs and their indications. We'll look at the light sources and dosimetry, the standard protocols for performing topical PDT, and I'm going to focus very much onto my past experience, which would obviously is working in the United Kingdom. And the protocols that we'll be talking about today are from the UK perspective and the European perspective. We'll look at some treatment outcomes from PDT as well. And I've included a couple of clinical slides of patients that I've treated in the past. So looking at the diagnosis and lesion prior to PDT, and then looking at a 3-month follow-up outcome. So hopefully those will excite you, because we've got some good outcomes. We do get some good outcomes with PDT. And then we'll look at potential adverse effects as well. So this slide, you can see the tri-wave MD lamp light source that you can deliver the red light and treat your patients with PDT. This lamp has a large, lovely surface area. It's actually, I'm quite jealous because it's bigger than the machine I've got. It covers about a 792 centimetre squared surface. So you can actually treat a large area with PDT, or equally if you had 2 lesions that were some centimetres apart, you can actually incorporate both lesions into one light illumination. So many benefits to this light source. So what is PDT? So photodynamic therapy is a widely non-invasive treatment for certain non-melanoma skin cancers, and allows treatment of small areas, large areas and multiple lesions with excellent cosmetic outcomes. I think that's one of the main benefits of PDT, is that we do achieve great outcomes for our patients, and cosmetic outcome is really important. For dermatological indications, PDT involves the topical application of a photosensitizing prodrug, 5-aminoleuvinuric acid, which we term as ALA, or its methyl ester methyl amyloleuvinate, which we term as MAL, MAL, which are both converted by the heme biosynthesis pathway predominantly into protoporphyrin 9, which we term as PP9, and then activated by the light of an appropriate wavelength. So commonly we use the red light for in conventional PDT, or more recently we have the novel application of daylight PDT. So it obviously depends on what we're treating as to which light source we will choose, and we'll talk about this as we move on. This in turn produces reactive oxygen species, singlet oxygen, resulting in apoptosis or death or necrosis of the targeted tissue. The selective uptake of the prodrug, ALA, shows a selectivity to the tumour site, and is used as part of this non-invasive, practical and clinically safe procedure, and very, very popular in the United Kingdom and Europe and many countries across the world. Topical PDT has gained popularity both in the NHS and private settings over the past 2 decades, and was endorsed by NICE, which is the National Institute of Clinical Excellence in the United Kingdom, in 2006. And I think my personal experience is since that date, it really has become a popular treatment and very much an important treatment in the cancer pathway in the United Kingdom. However, the history on PDT goes back a long way, back into the early 1900s. This is a picture of von Tappenher. So at the beginning of the 20th century, von Tappenher, a German pharmacologist, first coined the term photodynamic reaction. This term was chosen because of the observation of one of his doctoral students in their studies. In 1905, in cooperation with a German dermatologist, Gieseneck, von Tappenher successfully treated patients suffering from lupus vulgaris, secondary syphilis and superficial cancers with a topical eosin solution. Although the science behind PDT is very complex, it's a very simple procedure to perform. And in the United Kingdom, following training and education, it's routinely carried out by nurses, doctors, and technicians as well. So PDT has been approved in over 18 countries worldwide for at least one non-melanoma skin cancer indication. And as I've already alluded to, it's gaining popularity. We're still opening new clinics across the United Kingdom each month. So, you know, the potential is huge, really, and it's a fantastic service to deliver. PDT is commonly performed using the prodrugs ALA and its methyl ester MAL. As mentioned earlier, these prodrugs lead to an accumulation of the photosensitizer protoporphyrin 9. PP9 has several absorption peaks, with a 632 plus red light peak utilised most frequently for irradiation in treatment for a range of skin cancers, including actinic keratoses, superficial and nodular basal cell carcinoma, and squamous cell carcinoma in situ, so Bowen's disease. Whilst the 410 blue light peak is also utilised for more superficial lesions, such as mild actinic keratoses. And the prodrugs are relatively selective to the target lesion, so sparing good tissue surrounding, so, you know, further issues. Sorry. The prodrugs are relatively selective to the target lesion. So currently, there are 3 prodrugs that are licensed for the use of topical PDT in the United Kingdom. A good practice point would be to refer always to the summary of product characteristics on the Electronics Medicines Compendium when administering PDT, as there are different preparations and administering procedures for each license indication. So it's really important that you refer back to that all the time. The prodrugs include an esterified formulation, methylaminoleuvellic acid, MAL, which is Metfix cream, as manufactured by Galderma. And I think Galderma's had that product on the market since about early 2000, so 2001, 2002. And it's licensed for the treatment of actinic keratoses, squamous cell carcinoma in situ, and both superficial and nodular basal cell carcinomas. A newer formulation is the nanoemulsion 5-amyloleuvellic acid hydrochloride, ALA, which is Ameluz gel. And that's produced by Biofrontera and is licensed for actinic keratoses, field cancerization, and also superficial and nodular BCCs. There's also an ALA medicated plaster, Alacare by Medac, a German company, and it's licensed just for actinic keratoses. We also have daylight PDT, for actinic keratosis, and that's a more recent indication. I think 2005, that was licensed in the United Kingdom. Both Metfix and Ameluz are licensed for PDT in combination with daylight, which is increasingly being used as a light source in the treatment of particularly widespread actinic keratosis. So areas of field cancerization, large area on scalps as well. But again, I'm going to refer you back to the SMP for any of those products for the therapeutic indications and how to administer that drug onto the skin. I think we've already covered that slide really. So on to prodrug mechanism of action. So once the skin's been prepared, the prodrug is administered to the area to be treated at a millimetre thickness. And that's quite a subjective. So, you know, possibly what I feel is a millimetre thick and what someone else is. So it's a little, as long as we get roughly about that thickness, that's appropriate amount that we need. The area is then covered with a transparent adhesive dressing, covered tightly, and that promotes penetration of the active ingredient into the skin without a premature reaction to daylight. The patients then go off for 3 hours. So during the 3-hour incubation period, the active substance accumulates specifically in the disease cells that we want to treat. And here the transformation occurs into the light activating agent called protoporphyrin 9. And afterwards, the air is exposed to a non-thermal LED red light for about 8 to 10 minutes. It depends very much on the product you're using and your lamp choice as well. So again, you'd need to refer to the manual there. Now, although once you switch the machines on, it's red and it's bright, it's actually non-thermal. So I think that's a message that's important that we make sure our patients understand. Red doesn't mean hot, it means it's delivering the right wavelength, but it's non-thermal. So within the disease cells, the interaction of the accumulated PP9 with the light energy produces reactive oxygen, which is a powerful cytotoxin. This process, which is known as the PDT effect, destroys the disease cells without affecting the normal cells. So, you know, post-treatment, healing's very, very quick. And in my experience over the many years I've been doing PDT, I've never ended up with a ulcerated lesion, a site, or any problems post-treatment. The process using a blue light is the same, but will not penetrate as deeply into the skin. So it's well documented in the literature that using a red light in PDT will achieve better outcomes, particularly when you're treating BCCs and Bowen's disease. Because as I said, it penetrates deeper into the skin. However, the red light is associated with increased discomfort, unexpected local skin reactions, which we can predict. Again, that's a conversation we need to have with our patients so they have that understanding. And we manage their discomfort. We'll talk about that a little bit as we go on. So these are just product packed images of the photosensitizing prodrugs that I've already alluded to. So you can see you have Ameluz gel there on the left-hand side that's manufactured by Biofrontera. We have Metfix cream manufactured by Galderma, which has been on the market a slightly longer time. And then there's an image there of the Alacare medicated plaster. As I've mentioned before, this is just licensed for actinic keratoses. The patches are quite small as well, so you are slightly restricted into the surface area that you'd be able to treat with that patients. So unlicensed indications, and this is always a popular question that we get asked because, you know, people say, oh, is it just the skin cancers or precancerous lesions that we can treat? But there are a number of other inflammatory conditions that were reviewed in the British Association of Dermatologists guidelines in 2018, and we have the reference at the back of the presentation for you. And these are some of the dermatoses or diagnoses that have been treated by practitioners in the past in an unlicensed way. I think the problem with this is that often the protocols haven't been laid down, so it's not always clear exactly how or how many treatments these diagnoses will require. But we do know that acne has been extensively studied. Again, however, the consensus on the optimal protocol not defined, but PDT in a lower dose with a shorter incubation or a less penetrating blue light are probably likely to achieve a shorter term effect via a direct antimicrobial or anti-inflammatory effect on the skin. But in contrast, higher dose PDT probably promotes direct destruction of the sebaceous glands, and follicular obstruction may be reduced. So the recent guidelines that I've already mentioned suggest considering PDT as a treatment option for acne where standard treatments are ineffective or contraindicated. So I think that we're gaining more and more evidence as we go along for the supporting in the treatment of acne vulgaris, which obviously is a huge problem to many of our patients. The other interesting emerging area, I think, is the photorejuvenation in PDT. So there have been multiple studies have observed improvement in fine wrinkles, mottled pigmentation, roughness and sallowness in the skin, and following PDT an observed upregulation of collagen production with an increased epidermal proliferation. And one of the studies by Reinhold, again, we've popped this in the back of the reference section, suggested that PDT has been frequently reported to have beneficial cosmetic effects on treating the skin. The effect can be attributed to the removal of actinic keratosis lesions on the skin and irregular pigmentation, but also has an additional dermal effect as well. So the inflammatory response associated with PDT is often accompanied by the dermal formation of collagen, which leads to an improved skin appearance on the treated area. And I always remember treating this very, very elderly lady. She was 103 a few years ago, and she had a bonoid lesion on her jaw, which needed treatment. Even that age, she wanted it treated. But when she came back for her follow-up, so she was 103 and a half, this lesion had completely resolved. It had completely taken away all her wrinkles. So she did ask me whether I was prepared to treat her whole face. So I remember her, she was quite a character. But yeah, so we do see that benefit on the skin as well. And I think linking back to the European Dermatology Forum guidelines 2019, which we'll talk about a little bit in a moment. There's a lot of interesting data in there if you're interested in looking at some of these off-license indications and to see what sort of outcomes you may expect should you choose to deliver PDT for off-license indications. So light sources and dosimetry. So there are a range of light sources out there in the market that can be used for topical PDT, and it's important to ensure that the light source will deliver the necessary irradiance within the absorption band of your photosensitizer that you've chosen at a sufficient depth to destroy the target tissue, whilst causing minimal damage of surrounding tissue. The most common light sources used for PDT are the laser diodes, filtered lamps, or the LEDs. All my PDT experience over the 22 years has been with LED lights. They do have the advantage of a narrowband spectral emission with minimal cost and are virtually maintenance-free. And these are the most common light sources that would be used in the United Kingdom. Most light sources for PDT seek to utilise a 630 plus red absorption peak to improve that penetration of the light into the skin, reaching the targeted tissues. However, we do know that in the USA, the blue light is very popular and is commonly used. Although we know that the blue light shows the highest excitation peak, its penetration into the skin is limited to less than 1 millimeter. Whereas in contrast, the red light that we use commonly here shows a lower excitation peak with a product, but therefore penetrates deeper into the skin. So, you know, that's our chosen light source for these deeper lesions. For the first time in the United Kingdom in 2018, the British Association of Dermatologists published the first time service guidance and standards for delivering a photodynamic therapy service. These are available through the BAD website. You don't have to be a member, you can download those. And the aim really was to develop service guidance and core standards covering patient referral, patient information, consent, treatment, discharge. It talks about audit, it talks about managing patients' pain and discomfort. So, you know, if you're at the moment delivering a service or thinking about delivering a service in the future, it's certainly worth downloading that document and having a look through that. So, protocol for PDT. So we know it's well documented that over the years, successful PDT outcomes require the application of an appropriate prodrug. We need an appropriate light source and oxygen, thereby attaining the mechanism of action required. The resulting PDT reaction at the targeted cells produce a therapeutic result for the patient. However, lesion preparation is key to success, and therefore following the recommendation protocol according to the prodrug license will enhance success. And that's one of the key things when I'm teaching dermatologists or nurses around the United Kingdom, is that we really need to get the skin preparation right if we want to get great outcomes for our patients. The following treatment protocol refers to the use of the two prodrugs that are currently licensed in the UK. So we're going to cover Ameluz and Metfix. For the treatment of AKs, generally we have one cycle of treatment. However, treatment of both superficial and nodular basal cell carcinomas and Bowen's disease, we generally do 2 cycles a week apart. I mean, historically, we used to use 2 cycles for AKs, but as the years have gone on and we've had sort of good follow-up data, we now generally just do 1 treatment. So if we think about preparing our patient for treatment, so as I've already mentioned, to achieve the best possible outcome, it's critical that the area to be treated is optimally prepared prior to the patient's treatment. A really good practical tip, and there's one that I always teach when I'm talking to dermatologists and plastic surgeons, is to try and encourage your patient to possibly use a moisturizer regularly, maybe a week or 2 before they come for their treatment day, just to soften any thickened crust or scale that they have on the skin. As you know, often these patients will come to clinic and they've got sort of hyperkeratotic crust or scale. And we really need to make sure that we've removed that before we do our treatment. So if you can get them to apply a moisturizer, a paraffin gel, urea-based moisturizer, you know, before they come for their treatment day, that can really make a difference. It means we've got less to do on the day and potentially less traumatic for the patient. It doesn't really matter what moisturizer they use, whatever they've got in the bathroom cabinet is fine, but it really does make a difference. And, you know, obviously we would be giving patients pre-treatment information as well. And often the manufacturers of the prodrugs that we've mentioned will supply you with this information. So on treatment day, as we would be treating any patient, we would take their medical history, we'd do that assessment, we'd gain patients' consent, and generally we talk about either verbal or written consent. I mean, the BAD guidelines are really suggesting the gold standard would be to collect written consent from our patients. And we'd also be checking for any allergies. So particularly the ones I've mentioned here. So any hypersensitivities to the prodrug ingredients, porphyrins, soy and peanuts. Soy and peanuts are similar for both Ameluz and Metfix. So again, we wouldn't go ahead and treat if patients did have allergies to these and or any of the other excipients in the actual product. But again, you need to go back to the SPC, which they'll be listed there as well. So just to double check that. So this was my patient. This gentleman was in his 50s. He had a basal cell carcinoma on his back. I don't know if you can see my mouse here, but this was about 1.5 by 1.5 centimeter in diameter. It was histologically proven a superficial BCC. He didn't want surgery. He opted to have PDT. So the first thing we would do is to clean that area of skin. Now, with Ameluz gel, it's recommended that you use a 70% isopropyl alcohol wipe. Or indeed with Metfix, I think the recommendation in the SPC is with normal saline. We never quite know what patients have put onto their skin before they come to clinic. And if they've been doing, as we've suggested, by applying a moisturizer regularly, often they come into clinic with thick grease on the area. So we definitely want to remove that to make sure that we've removed any grease from the skin surface. So that would be our first step. Our second step would be to remove any crust or scale from the lesion. Now, hopefully, if they've done as we've asked and they've prepared the skin at home before they've come to clinic, hopefully it won't be too bad. But even so, if you've got an older patient or an elderly patient that can't access the area you're going to treat on the back, then we still may need to intervene with some preparation. So gently remove any crust or scale. And it doesn't matter what tool you use, whatever your preference is really. Often clinicians will use a ring curette. In this clinic, we had a 15 disposable scalpel. There are some centres that use an exfoliating pad or an exfoliating glove. And sometimes just roughened gauze will be enough. But as long as you ensure that you prepare the lesion, surrounding tissue, and I'd like to think I've just disrupted the stratum corneum a little bit with that preparation to really ensure that I get good uptake of the product into the skin. Now, you may cause some pinpoint bleeding, which we do. You can't help it. If there's a fixed scab there, it's going to need to come off and we may cause bleeding. But just to press the area with some gauze until it stops, and then we're ready for our next step. So this gentleman, as I've said, had a superficial BCC. So I would take a 5 to 10 millimeter surrounding border. So from what I can see clinically to the peripheral border, I will take out a 5 to 10 extra border out, demarcate it with a surgical skin marker pen. And I know that that's the area that I need to apply my product onto. And I think if I'm treating a field area, so a large area, I would just put some little dots around the large area that I'm treating so that it's very clear as to where I'm treating. And I think the other tip really is that when later on when you're applying, you're positioning your red light, once you've got the light on and you've got your operator glasses on, sometimes it's difficult to see where the lesion is. So if you've demarcated it with a surgical skin marker pen, really does help the focus. And I've learned by that in the past. So just that tip to pass on to you, really. So we've prepared the skin, and we're now ready to apply our prodrug photosensitizer to the area. So you can see there you can use a fingered glove. So if you've got some non-latex nitrile gloves on, I mean, it's not a sterile procedure, but if you've got some gloves on, you can put the product onto your fingered glove and apply it in that way. You could use the side of that blade as that practitioner was doing, or you could use a spatula. A wooden spatula is quite a good thing to dispense your product onto the wooden spatula, take that to the patient. Millimeter thick, as we've mentioned, taking it out to that demarcated border and then applying a transparent adhesive dressing on top. That will fit tightly to the skin, ensure you've got no air bubbles in there, and you know that gel or cream's not going to move anywhere. It's quite safe in there. And then your patient, once you've put a photo-occlusive dressing on top or a bit of gauze and tape, then your patient's free to go off for the 3 hours. Some centres make sure the patients stay within the organisational building. I used to send them off out of the department to let them go off for a walk, or some patients would go home and then come back 3 hours later. So once your patient returns for the light illumination, and I'm pleased to say that I've never had a patient that's not come back, and they're usually pretty on time. I mean, we talk about the optimum is 3 hours later. So the patients will come back, and then what we would do is remove the dressings and just wipe the photosensitizing agent off. So whether you can use saline at that point. Again, this patient chose to sit on a chair and lean on the couch. So that was the position he wanted to be in. Equally, you might get the patient on your patient couch. I think particularly if you're treating head and neck, it's good to get the patients onto a couch and then you've got the control. Otherwise, they might be moving around a little bit, which isn't great when you've got to ensure you keep your distance in the correct measurement, which we'll talk about. So the patients come back, we've wiped the cream off. Now, the next stage, you can see on the right-hand slide there, this shows coral fluorescence. And if we use a Woods light, a UV lamp, the Woods lamp that some of you may have in your dermatology clinics or aesthetic clinics, we can see a coral fluorescence where we can see that there's an uptake of this drug into the targeted tissue cells, and it's fluorescing, that coral color. Now, you don't have to do this step. It's not going to affect your outcome. You may not have the facilities. So you may not have a Woods light. You may not have a darkened room. But if you can do it, it's a great thing to be able to do. And you can just sort of visibly see the uptake there of your product into the cells. So it's quite nice to be able to do that. So we would get our patient position comfortably, whatever that is for the patient is individual. And we would then position our light source. And generally with the LED lamps that I've used in the past, we use a 5 to 8 centimeter distance from the light to the lesion. So normally what we do is we cut off a little sort of measurement, the disposable wound measures, 0 to 8 centimeters, and use those so we can dispose of them in between patients. So that would be your guide, your measure, so that you don't want to be closer than 5 centimeters. You don't want to be further away than 8 centimeters. And that will deliver a dose of 30 joules per centimeter squared. So some of the LED lamps are preset on 37 joules. Some of the machines you can use the menu button and input however many joules you want to deliver. A lot of them are already set to 37. And with the photosensitizers that I've alluded to, with MAL, Metfix and ALA with the amylose nanoemulsion, that would be the right protocol. Now, the light we've mentioned is a red light. It's bright, but it's uncomfortable, really. It's not harmful to our eyes, so we don't have to put laser warnings up, etc. But it is quite bright and uncomfortable. It's like sort of looking at the direct sunlight. So we do need to wear eye protection, both the operator and the patient as well. And then, as I say, the illumination times may vary according to the light source that you're using. So again, you just need to refer back to your manual for that particular light. So during illumination, patients may experience warmth or discomfort, even though we've reassured them before we switch the light on that this is non-thermal. Yes, it's red. Yes, it looks bright. Yes, we've put glasses on you, but actually it's non-thermal. But the reality with red light PDT is that patients may feel this warmth tingling sensation, and sometimes patients find it extremely uncomfortable. Everyone's going to be individual and different. I think we sometimes get our patients to take some analgesia 3/4 of an hour before they come for their light treatment. That's something they can choose to do should they wish to. So we often get the patients to do that, self-administer that themselves. And And it is well documented in the literature about the potential discomfort that patients may experience. There are some lamps that have the facility of reducing light intensity over a slightly longer period of time, but delivering the same dose. So each light or lamp is slightly different. A lot of them have got a built-in fan, so often that can be beneficial to the patient. But as a dermatology nurse over the many years, I think the best thing we can do is talk to our patients. And you can find out all sorts of secrets when you're standing there for 10 minutes with a patient. We call it talk anesthesia or vocal local. And generally that's sufficient to get your patients through the treatment. We can use cool water spray. So sometimes we have a little water spritz, like the cosmetic water sprays, and just spritz a little bit of cool water on the area. Or some centres have laser cooling devices as well that they might use in as well as the water spray. There's quite a section in the BAD service standards about managing pain or discomfort with red light PDT. But for me, it's never been a huge problem. We get them through it by chatting to them. And then after the 10 minutes, they say, oh, where did that time go? So it does go quite quickly. You can infiltrate local anaesthetic, generally preferably to not use adrenaline. So this may cause vasoconstriction of the blood vessels, and you may not get the PDT reaction that you want. So if you use local anaesthetic, if you infiltrate, use plain lidocaine. There's no real evidence to support the use of topical anaesthetics onto the skin. It's deemed not to be really helpful at all for patients undergoing PDT. So that's generally how we get our patients through it. So once the illumination time's completed, and the machine will switch itself off, and if you have had that Woods Light UV lamp facility and you did check for coral fluorescence, if you now go back to your patient, go through the same again, use your Woods Light in a darkened room with the blinds down, hover the lamp over the area, you'll see that coral fluorescence has gone. So you've got almost see that dullness there, but, meaning that we've had that photochemical reaction. And, it's a good sign for us to see, as I say, but it's not essential. You don't have to do that. So once we've rechecked for, once we've checked for photofluorescence, if we're going to do that, we would just simply put a dressing on after the treatment's finished. We normally recommend a non-adhesive light dressing. You could put a shower-proof dressing on for 24 to 48 hours. Once the light's switched off, you may see erythema, you may see a little bit of edema in the tissue, you may see a few vesicles, little blisters. That's all sort of a normal reaction that we would expect to see, and that usually diminishes and dampens down over the next day or so. So the patient still may have a burning sensation, particularly when the lamp switched off. And if the lamp has an inbuilt fan, once the lamp goes off, the fan will go off, and they sometimes say, oh, it's still feeling a little bit warm, but that all gradually diminishes, and we usually recommend taking some analgesia when they get home as well. But it's not normally a big problem at all. Very, very low infection rates. So it's all sort of the post-treatment downtime is very minimal. We always give them post-written information. And if we're treating BCCs or Bowens, we will give them their appointment for their second session, ideally a week later. But there are some times when we have to prolong that up to 2 weeks. And that hasn't, in my personal experience, affected the efficacy of the treatment. But generally, it's the 7 days later that we do. And then usually follow up 3 months later. And I know that might be different in private practice, but normally we would say, we probably need the 12 weeks to actually see what our ultimate treatment outcome is before we decide whether we discharge, whether we've had 100% clearance, or whether we need to repeat treatment or use another modality. So again, it's normally that 3 months later. So these are just some clinical slides. So this was a patient I treated. This was a lady that came, an older lady. She had a histologically proven basal cell carcinoma on her back. it was 6 by 6 centimeters diameter, so quite a big lesion. And you can see there our follow-up, basically 3 months follow-up. So she had a really good treatment outcome and was very, very happy with that. As I say, you can see the cosmetic outcome there. Not that it was important for this lady, it was on her back, and this was a skin cancer, so it needed dealing with. But you can imagine if that had to be dealt with surgically at that size, you know, it would mean a graft and all sorts of potential post-treatment issues, but very straightforward. And this gentleman was another patient of mine who had, again, histologically proven superficial basal cell carcinoma on his right chest. I think you can also see there he'd already had it curetted prior to coming to clinic, and this was basically the recurrence of the lesion. So we treated him with 2 treatments a week apart, and that was his 3-month. He's got a bit of a suntan there, so that's not good, is it? He's been out in the sun again. But you can see here good clearance, possibly a tiny little area there that hadn't completely cleared, which we might have, I can't remember whether we used cryosurgery or a topical agent for that, but good outcome for him, which would otherwise been a big procedure surgically. So aftercare advice, I mean, it's quite straightforward. We advise the patients to try and keep it covered for 24 to 48 hours and keep it dry. I think if a dressing is not practical, then we normally get the patients to, make sure that they sun protect themselves as well. And then we always give them written information to inform them of what to do. And how to care for the treatment site as well, but normally never a major problem. So known adverse effects on PDT. So I've already mentioned, as soon as the lamp switches off, we may get erythema, swelling, vesicles, maybe a bit of weeping, but it's all, for me, it means the treatment's worked. I think if we warn our patients that that's a potential, it's never a problem. And it's well documented about the pain and burning. I've mentioned erythema, and that can, be present for a few days, the inflammation there. And if you get swelling in the tissues, you're going to get some oozing. One of the benefits of having the dressing on for 48 hours. And again, it's documented sometimes about hypo and hyperpigmentation. I think over the many years, I've only had a couple of patients that have had hyperpigmentation, but has resolved within months following their treatment, and rarely contact sensitivity. I had one patient that had bilateral bonoid lesions on both lower legs, and she was just coming back every couple of months for more cycles of treatment, and after about 2 years she did build up a contact sensitivity to the product, and we had to unfortunately change our plan of action for her. But I think it is quite rare that that we have patients that have contact sensitivities there. So I think we've sort of taken you through, hopefully, as much information as we can impart with you today. And I mean, it is a great treatment. I've been very fortunate to be involved with it for many years, both in the NH setting and a private setting. It is a widely used non-invasive treatment. I think that's quite a key thing for some patients, non-invasive treatment compared to surgery or having to apply topical therapies over a long period of time. It's highly effective if we, using the standard protocols in the licensed indications, and we've mentioned actinic keratosis, BCCs, and SCCs in situ Bowen's disease. And we do know, and hopefully you can see even with my patients today, we've had some great cosmetic outcomes over conventional therapies. And I think the exciting thing, it will be the future. And as we're, accumulating more and more evidence that supports the use of PDT for acne and photorejuvenation and some of the other inflammatory skin conditions that we see, And although we know those protocols are not yet defined, but I think the European Dermatology Forum guidelines that were published in 2019 are most definitely worth a read if you've got an interest in developing your service in that direction of some of these off-license indications. So hopefully we've supplied you with a reference list there. And again, the top one is the British Association of Dermatologists, the guidance that we spoke of there. And the bottom Wong paper are the BAD most recent PDT guidelines as well. And I think the next slide will give you further reading. And these are the most recent part 1, part 2 European guidelines. And again, part 1 will take you through the established indications, and part 2 will take you through these emerging indications. So I think the future is quite bright for some of our patients, and particularly for photorejuvenation and acne and some of those inflammatory conditions that we struggle to treat sometimes. Just listed there the prodrugs that we've discussed through this presentation, and links to, or sort of the link there that you can go to look in more detail about the specific characteristics of those prodrugs. And again, we've just got some abbreviations there. So this is the lovely Tri-Wave MD lamp, and which I mentioned, we saw that similar slide in the beginning. So obviously a powerful LED lamp for medical, aesthetic and PDT applications. So it's very exciting that this new lamp has got the PDT facility on it. And the benefit there is you've got this large illumination area, which is fantastic for, you know, on the back of a patient, or on a scalp if you were treating a scalp. And also if you've got, you know, and often we've got 2 lesions near each other. So, you know, you might have a lesion on the arm and then there's one a little bit further down, and this larger illumination area will be able to, you can incorporate 2 lesions or 3 lesions in one treatment. So I think it's great that we've got this facility. So thank you. I hope that was interesting. And I think Louise is going to join me now. And I think Louise has got some questions, I think.
Yes, thank you so much, Paula. That was a lot of information to share. I know it's, you know, it's a new treatment area for us. You know, we've been very focused around sort of cosmetic dermatology applications, but, you know, an in-demand, I think, sort of service that people can offer. And, you know, this, you know, the development of the Tri-Wave MD is really able to extend, you know, this service. Yeah. And like I say, you know, we've made sure that we incorporate the correct wavelengths that are going to target that. So yeah, we hopefully our clients with the Tri-Wave MD will now be able to sort of look forward and sort of help, you know, incorporate this into their practice. So, but yes, we do get a lot of questions, and I know I've shared some of these with you, but I think, you know, some of them we may have touched on already. So if we have, but I'll read them out just to make sure that, you know, we recap on everything. So I think, yeah, we did talk about sort of the off-license indication, but you know, a big area that definitely I've sort of had questions on is acne, or, you know, what are the indications can PDT treat?
Yeah, no, I mean, that's one of the exciting things, I think, Louise, that we're getting more and more data and information about some of these off-license indications. And even over the years I've been doing PDT, some of the dermatologists where I've been working would refer someone with necrobacter lipoidica, or a scarring area, or, you know, porokeratosis. So that's often I've been sent patients, and maybe there isn't a huge amount of evidence to support it, but for some of these patients there is little other treatment. So I think you know, it's always worth considering, and I think the guidelines and the papers that we've got in our reference list will help some of your customers actually dive into some of those papers and actually have a look at what they can use. I guess the problem is, is that we still haven't got these defined protocols. So people want to say, yeah, I want to have a go, but actually, how do I do it? So often clinicians may still use the standard protocol that we've already talked about with the non-melanoma skin cancers. But I think the European guidelines will be useful for some of those customers of yours that actually do want to treat off license way. So I think the futures, we're getting more and more data, and so it's quite exciting for our patients. Yeah,
big area of research. And I suppose earlier on about the mechanism of, let's say, particularly with acne, because we know that with blue light, just standard blue light treatment for acne, it's about increasing the porphyrin, the natural light sensitivity, that oxygen reaction. So it's you're still using the same, you still need the same, let's say, ingredients, or you generate that, but it's obviously how we can maybe speed the treatment up. So we would typically say maybe sort of 10 to 12 sessions of blue light only treatment for acne, but this is something that could reduce a much faster treatment outcome for the patient.
Very good. It's nice to think we've got some new applications to look forward to in the future, so it's great.
LED is still a very safe, LED a standalone is obviously a very safe treatment to administer as well. So
absolutely.
But yes, we've got the reading reference list. So we'll share this presentation out with the viewers anyway. Again, I know we've touched on this, but what is the difference between red light PDT and blue light PDT, and how do you select the best wavelength for the indication?
I know it's slightly different from the USA, because I think the blue light is very much more, it's very popular in the States, but certainly my experience is, well, we know that the red light has a longer wavelength, and the blue light has a shorter wavelength. So we do, in terms of treating non-melanoma skin cancer, in terms of treating BCCs, whether they're superficial or nodular, and the Bowen's disease, our choice would be to use the red light, because we think that's the most appropriate wavelength, that we will penetrate the deepest into the skin, and enable to reach those disease cells that we want to treat. So in terms of mild to moderate actinic keratosis, we do know that we can use natural daylight, and natural daylight is as effective as red light, according to the studies that have been conducted, and that's in sort of Australia, Scandinavia, and European countries. So I think for the red light, we can treat actinic keratosis with the red light as well, but obviously a lot of clinicians are choosing to use natural daylight. But certainly if we're treating the other diagnoses, BCCs and Bowen's, we do need the red light, and that's generally the European consensus, I think, as well.
And with the nice thing with our Try with MD is that we've got both wavelengths in one device, so the practitioner can choose
popular options. So
we give those, we give that option, and I think it's one of the only lights that we've available that we've got that. So what is the difference, so the advantages or disadvantages between activating ALA with sunlight versus a lamp, an LED light source?
So I think the main thing to say here is talking about sunlight. We talk about daylight. So I think we don't need, when we're delivering daylight PDT, we don't need sunlight. It's just natural daylight, and often clinicians get a little bit confused about that. But in terms of natural daylight PDT that we've had licensed since 2015, we can only treat actinic keratoses. So we can't treat BCCs and Bowen's, because, again, going back to the depth of penetration of that lamp wavelength, so we can only treat actinic keratosis. So we do have that restriction when we're delivering daylight PDT.
So, and obviously we know daylight also has the red wavelengths and the blue wavelengths as well, and you deliver them all together. But I suppose, is it then at the treatment time, because obviously you're not necessarily controlling the amount of energy, so possibly time's going to be longer?
No, you're right, Louise. So when we talk about red light PDT, we talk about a long incubation of the drug on the tissue cells, and then a short illumination, so sort of 8 to 10 minutes of illumination with the red light. But with daylight PDT, we have a short incubation of the drug on the skin. So in other words, we put the drug onto the skin, and then within 30 minutes, we send the patient outside for 2 continuous hours.
Right.
So instead of that short illumination with red light, we've got a long illumination of 2 hours with natural daylight. And although for actinic keratoses it is more comfortable for patients, yeah, they have 2 hours outside. The other thing that we do have to think about is the weather. You know, obviously it's weather dependent, natural daylight. So in Australia, they're probably thinking, hooray, we can do it all year round. But we're in the good old UK here. So, you know, we have to think about our season. So it's restricted to March through to October. We can't really deliver outside of those months with natural daylight.
From a clinic perspective, if they want to offer a consistent service to their patients, then light source is obviously, is going to...
Yeah, absolutely. You've got the best of both worlds then. And
like I say, quick illumination is obviously a benefit as well. So, so I think we've just touched on this anyway. If an ALA manufacturer specifies a protocol for daylight activation, could you still use an LED light source, or are we just really better to stick with the protocol that the ALA manufacturer suggests?
Yeah. So I think my answer would be, Louise. So mild to moderate AKs and areas of field cancerization can be treated with daylight PDT. And prior to daylight being licensed in 2015, we only had a red light source to activate the drug. So I think the answer to the question is yes. Red light LED can be used, but again, link it back to the manufacturer. And, you know, just inquire through them just to check that you've got everything in place correctly. But I'd say yes would be my answer. Yeah.
Just a sort of another question that's just sort of come up, but with daylight PDT, so we let's say with red light PDT, we say 37 joules. Obviously, we can measure that very accurately.
Yeah.
But daylight PDT, is it still
measurable?
So I know it's different.
No, it's a good question, Louise, because what the scientific basis is telling us that if we're delivering daylight PDT, say for instance in the UK, and our temperature is above 10 degrees, because we do know we want the temperature to be above 10 degrees, and it's enough natural daylight out there. So within the months March to October, above 10 degrees, there should be enough daylight out there. So we need to deliver 4 joules per centimetre square in daylight PDT. Now, for most of the time, we won't know that unless we use a lux meter. So a lux meter will measure light intensity. So, you know, sometimes I've got a lux meter. So sometimes if I was treating a daylight patient and it was pretty heavy cloud and I'm not quite sure whether there's enough light out there, I might just stick my lux meter outside the door and measure. And what we're looking for is 11,000 lux, which is equivalent to delivering 4 joules per centimetre square. And that's kind of the measurement that we go to. So yeah, it's kind of a little bit more difficult because you're reliant on enough daylight being out there, whereas with the red light, you've got the control, you know, the dose, you know exactly what you're delivering.
In terms of booking sort of.
Yeah.
No, it's just, it's just interesting to see that control. And obviously more wavelengths, so it's more about energy delivery again as an accumulation rather than specific wavelength targets. So we talked about contraindications. Sorry. So what are the key contraindications to somebody having the PDT?
Yeah. So I think because I think it's always important to remember. Again, I keep going on about referring back to the summary of product characteristics, and I apologize for that. But because each drug has its own different characteristics and contraindications, that, you know, we should always relate back to that individual SPC. But we do know that patients with a diagnosis of porphyria would be most definitely contraindicated. So we wouldn't be treating overloading patients with porphyrins. But it's quite a rare diagnosis, and I would, you know, the clinician would be well aware of that. So, but generally you need to refer back to that specific to see if there's anything particularly that you need to think about. And obviously we've mentioned about the potential allergies in terms of soya and peanuts, I think for both of the photosensitizers that we've mentioned.
And I think maybe that obviously we've got the light and, you know, potential, although there's very limited contraindications to actually the light treatment, but I suppose it's taking that into consideration as well. I mean, we talk about things like people that are epileptic, or so we have a, you know, we have a small number of indications, but obviously drug indications or contraindications, sorry, to consider as well. But it is very limited, I'm sure.
And that's one of the sort of safe things about PDT. You know, it's very straightforward, and we don't have too many sort of red flags to alarm us. I mean, again, I think if you go back to the specific SPCs of those drugs, you know, sometimes it might mention if someone was on loads and loads of different drugs that made them very photosensitive, you know, they may get more of a phototoxic reaction. So just to be aware of that, really.
Yes.
Yeah.
But, with the consent, I think we're coming to this actually. We talked about like obviously making sure they fill in, you know, like the, you know, patient assessments.
Yes.
Treatment. So a PDT consultation form. So obviously, as a, you know, we're the manufacturer of a device, but obviously then you've got the product, and we obviously can't control what products our clients are using. So would you say that sort of any sort of pre-consultation and aftercare advice should really come from the manufacturer of the ALA? Because
I do. And that's totally been my experience, Louise. It's as you say, as a manufacturer, you don't know exactly what products people are going to be using. You know, sometimes people are using off-license products that are mixed up in pharmacy as a special product, and we don't know, you wouldn't have any control on what people were using. So in terms of my experience with the pharma companies I've worked with that have manufactured photosensitizers, we've always supported the customer or with good documentation on that surrounds that an individual product.
So from a clinic, because it is something we get asked for, so any sort of support materials for the PDT treatment, the clinic should ask their ALA supplier or manufacturer for all of that information, and then just follow our guidelines for just the LED sort of light source part of the treatment.
Definitely.
We did have a specific question around a cream called Photodynamic. I don't know if it's so if a patient is using that, I don't know what, can you just explain what the cream
so Photodynamic cream is basically a sort of like a chemical drug that destroys tumor cells. So in essence, it's doing the same thing as PDT. It's been around for many, many years, and it's well known. It's a very effective treatment. Patients have to use this sort of once a day for 4 to 6 weeks to the area that they're going to, you know, the area that they need to treat. It does give quite a florid reaction, so they can get a lot of redness, a lot of erythema, and sort of soreness with the treatment, and it's basically aimed to produce this inflammatory reaction and destroy the cells that we want to deliver. And if patients can go through that, they can get a very good outcome. However, it's, you know, some patients find it quite alarming because they end up with quite a raw, sore area, and not everyone can cope with that. I think the question is, how long should they wait before having LED treatment after that? I mean, again, I think I'd probably push that back to the manufacturers of Photodynamic to see what they recommend through their medical department. But we do know that we do a lot of combination therapy as well. So for these patients that we've spoken about today, we do sometimes combine treatments. So it may be they have some PDT and then 3 months later, we give them a prescription for some Efudix or a Miquimod or some of the other topical treatments that dermatologists and plastic surgeons will use. So sometimes we are combining treatments, but I think it's good to have a period of time in between so that you see the success of one treatment compared to the other. Otherwise, if you're mixing them together very closely, you don't really know what's helping them and what's not. So I think my answer would be probably go back to the manufacturer of Efudix, see what they recommend. But yes, sometimes we do combine therapies, but I think you have to think about the period of time in between.
Yeah, and also the Efudix cream may be used on larger areas, maybe where you've got more AKs over a larger area, or
yes. I mean, that's I think you can do, but because sometimes patients get quite a florid reaction and quite an aggressive reaction, I think most dermatologists, plastic surgeons or doctors would be a little bit cautious not to treat such a big area initially, just to see how they react. Yeah.
So another question, actually, which I think is can be a little bit confusing, is around the term 5-ALA. So, we talked about ALA, we talked about the different prodrugs, but 5-ALA, so does that indicate, does 5 mean it's 5%? Does it indicate strength?
No, it is confusing, isn't it? So this very sort of succinct answer would be no, basically no. It's not related to the strength of 5-ALA. 5-ALA is an organic compound in the porphyrin synthesis pathway. So, that 5 doesn't mean a strength. And often I can kind of equate this to people often ask this question. And I often think, so for instance, someone was using a steroid cream, and they were using a Betnovate steroid cream, which was 0.5%, say, which is a potent steroid. But then someone also had 1% hydrocortisone. And because it was 1%, they think that's stronger than the 0.5%, but actually it's completely the other way around. So I think sometimes you have to ignore percentages and dive a bit more into the science, really. But so the answer is no, it's related to the compound.
Because sometimes we hear 5-ALA, sometimes we just hear ALA, sometimes we hear
very confusing, isn't it?
It is, but I think for some of our customers, if they're just maybe starting or thinking about starting to offer this kind of service, it's hopefully this will just give a bit of overview information. Yes. Some of those frequently asked questions. So we talked about 2 different kinds of prodrug. You've got your ALA, you've got your MAL for the PDT. But so is the reaction the same? Obviously, it's just different formulations, but is the reaction pretty similar?
Yeah, so I think what I'd say, so the reaction or the mode of action, we're aiming to do the same with ALA and MAL PDT, but the characteristics of the individual prodrugs may mean that you get different outcomes. So I think. So the individual prodrugs, the efficacy of the treatment, and therefore the treatment outcomes may vary. And I think this is where you probably want to have a bit of bedtime reading and go, certainly I would be looking at the clinical studies that were conducted around that product to see what patient outcomes were, through the study. So I think I think the answer to that is yes, we're aiming to do the same with both, and the both would do the same, but whether one might be more effective and achieve better outcome results, depending on the diagnosis, is something that I think we as clinicians need to do a bit of that reading behind that.
Yeah, I suppose also it depends what's available in each particular country.
Yes, absolutely.
It does vary, so it's worth checking locally as to what.
Definitely.
So you mentioned so we talk about obviously skin preparation, we put the prodrug on, and then there's a 3-hour incubation time. I know we touched on this about it's a shorter incubation time for ALA, for daylight PDT. So is 3 hours pretty standard? Is that the recommended time to reaction?
So certainly with the prodrugs we've mentioned, so we've talked about ALA, the amylose nanoemulsion, we've talked about MAL Metfix cream. So certainly for those two, within the license and within the SMPCs, we talk about 3 hours. So we know that that's the optimum time to get the patients back. And I guess that sort of links back to all the clinical studies they've done over the years on those products. However, you may get clinicians in certain clinics that believe that they could reduce that to 2.5 hours or 2 hours, and then get the patient back after 2 hours to do the illumination. And there would be many clinicians that want to do that, and that would be up to them, their personal choice to do that. And I guess we don't know. I think, some people may not need 3 hours before they have the area illuminated. But I guess as a nurse, I've always followed the science, the standard, the protocols that I've had to deliver it to be safe and effective. So so generally it's 3 hours, but some clinicians may tweak that to a little bit less.
You think it can vary depending on where it is, if it's an area that's a bit thicker of or again it's.
I don't know. Generally, I think most people stick to the 3 hours, to be honest, Louise. Yeah. But I think you may get some clinicians that have done some sort of studies in the past on PDT and photosensitizers, and they may have demonstrated that they could do a slightly less incubation time. And I think if that's what they want to do, then that's fine, as long as they're getting good outcomes. But generally, if we're teaching practitioners, we use that 3 hour window.
Perfect. And I think the next question kind of follows on. So we've said, does the amount of PDT treatment, so you said, 1-2 cycles maybe, and then but does the amount of treatment depend on the indication and the severity?
Yes, I think we definitely know with mild to moderate, mild AKs, mild to moderate AKs, we would do 1 cycle of treatment normally. But I think I mentioned in the presentation that if they were more mild to moderate, more hyperkeratotic areas, AKs, then a clinician may choose to do 2 cycles of treatment, and that would be fine, a week apart. So generally it's 1 cycle, but if they were very thick lesions or lesions that hadn't resolved, then you might want to do 2. So the protocol really is 1. But with BCCs and Bowens, most definitely 2 cycles a week apart.
By cycle, you mean a treatment? Yes. So you just
sorry. So it's session. Maybe I should say a session. So 2 sessions a week apart. And things get in the way for patients. So sometimes patients will come in and they say, well, actually, I can't come back, so I'm on holiday. Can I come back in 10 days or 11 days? And that's absolutely fine. I mean, we still would retreat up to 2 weeks later if they needed their second session 2 weeks later. When I was full-time in one of the trusts in the UK, we did an audit on our patients that were treated 7 days later and patients that had to come back 14 days later, and it didn't seem to reduce the efficacy of the treatment. Yeah.
And then obviously you wait, and then they come back for a follow-up. Maybe. And is there a set period in that time? Did you say 3 months? Maybe.
Yeah, no, I think that's ideal, Louise. I think if you get them back too quick, you haven't really got a great picture of their treatment outcome. I normally say to patients that, this is going to obviously take time for the skin to repair, to settle down, and then we see the best results, or we see the most realistic results 3 months later. So generally it's 3 months, and then you either know, have they cleared, or do we still need to do more treatments? So I think that's the best thing. I think in the private practice, some clinicians may get their patients back a little bit earlier, purely because of that situation. It's a private practice, but generally it's 3 months.
Yes, and the skin's got that full
repair, and definitely.
How would you? So is there any way of knowing that it's definitely, that's it, there's no more treatment needed, or is there any sort of gauge or measurement of that?
Well, not really. I think generally it's done by clinical assessment. So the clinician will 3 months later see the patient back and assess the skin. But when they've conducted clinical studies over the years, they might have rebiopsied. You know, we don't really want to have to do that unless it's absolutely necessary. But if there's any uncertainty, you know, they might just take a tiny little small biopsy again just to assess. But generally, it would be done on the clinical assessment by the doctor.
Perfect. Okay. And we did talk about obviously patient comfort during the actual PDT treatment, because we know it can be a bit uncomfortable and not so pleasant. But so we talked about talking to them, cooling. But so in terms of actual cooling with maybe, like, say, cold air, if someone's got a cooler in their clinic, is there any evidence to suggest that that could reduce the efficacy? Is it doing anything to the vascular sort of structure?
So I think it's a really interesting question, Louise, because we do get asked this an awful lot. And I cover, you know, I'm very lucky to be able to go into sort of many clinics around the UK, particularly south of England at the moment. And a few of these centres have got these wonderful laser cooling devices, which are fantastic for the patients if they're having PDT. However, you're quite right, it is controversial. And I think if we had 10 dermatologists here, you know, 5 would say no, they're fine, and 5 would say no, they're not fine. So actually in the literature, it does say that there's a concern that the associated reduction in temperature, if you're using forced cooling, may reduce the PDT effect, and that more studies are really needed. But in reality, in clinical practice, and there are some quite major hospitals, teaching hospitals in around England that I've been into that use them and get great results, and truly believe it doesn't affect the efficacy of the treatment. And it can be of great benefit to patients, because it really does make a difference. However, the amount of clinics that have got these devices are minimal. So most centres don't have that facility.
Yeah, I think you may find more like aesthetic, depending again on like I said, private aesthetic practices that
And I think you'd have to balance up the fact, if you had that device by you and your patient was really struggling and you tried all the other interventions, then certainly I would go for that device and have a go at using that. Otherwise, what happens if you have to abort the treatment? You know, so if it gets the patient through it comfortably, then I think it's definitely worth thinking about.
Just one thing, obviously, we've got our TriWave MD customers sort of viewing this. But with the when we developed the TriWave MD, you know, it was 3.5 years in development. It took a lot of time. One of the challenges that we actually had was about sort of keeping the temperature regulated, keeping it steady so it doesn't get too hot. Obviously, we are delivering a lot of energy there. The red light in 20 minutes can deliver 126 joules. So it is a lot, but we can control that. We can make custom programs by, you know, so if we need 37 joules, we can deliver that in either over a longer period of time or a shorter period of time.
Brilliant.
Make it more comfortable. So it is so versatile and adaptable. But over the front of the LED pods, over the front of the panels, so it's not cooled air, but we have a very gentle passive airflow that across the front of the board. So it just helps to regulate that sort of that temperature to make it more comfortable. So there's no cooling that's going to be detrimental to the effect, but just having that very gentle sort of passive airflow can just help, you know, will definitely add benefit.
Yeah, it makes a huge difference to the patients, Louise. So that's great. You've got that inbuilt in there. Brilliant.
Yeah, an added, like I say, an added. Just another question that's sort of come in, but in terms of so we've done the treatment, and then you said about the wood, you know, using the wood lamp to make sure that, you know, you can see that the uptake of the or the reaction has happened. And obviously for clinics that don't have that facility, I know wood lamps aren't, you know, it would probably be worth investing in one if that was the case. But is there any way of knowing that it's definitely, you know, are there any instances where a patient might not have fully, you know, that it might not have fully activated?
I mean, I've never experienced that, Louise. And, you know, most patients, if they So say, for instance, we haven't used the Woods lamp facility. So we haven't used that. And then many centres haven't got the Woods lamp or a darkened room. So you can't do it, and it doesn't matter. But I think if you've got a patient that you've administered the drug onto and they've come back, you've switched the lamp on, they're going through the illumination period. I think if someone said to me, I completely felt nothing at all in the 8 to 10 minutes, however long the machine was going, I might be a little bit worried about that. It's extraordinarily rare, if ever, have I known a patient that hasn't felt a little something. I'm not to say everyone's got to have, on the scale of 0 to 10, 0 being no discomfort, 10 being really uncomfortable. Sometimes you get patients say, oh, it's like a 1 or a 2. Some patients are on 10, within seconds. Everyone's different, but it's very rare that nobody feels anything with red light PDT.
And that's an indicator of obviously that you've got that
some sort of PDT effect. And also at the end of the treatment then, Louise, then you would look at the skin, and if you saw erythema, a little bit of redness, then again it all adds to your confidence that that's actually something's happened there, something good has happened.
The severity of the pain is linked to the severity of the indication, or can it just be people's tolerance?
No, I think so number one, I think you're right, tolerance is a big factor, so everyone's pain threshold is different. We can correlate the discomfort issue to the good preparation. So if you've done good prep, so they've done studies where they've looked at different operators. So they've said they've looked at 8 different operators, and they've done an observational study. They've observed them doing the skin prep. They've then observed the coral fluorescence when the patients come back, and then they've observed the discomfort potentially, and then the outcome in 3 months. And there is a direct correlation between how well the skin's prepared, how much coral fluorescence you see, possibly how much discomfort the patient may feel in a good way, if you can think of it in a good way, and then the outcome, a good outcome. So, they've done studies to correlate that. So I think it is kind of indicative as to the outcome that patients might get. But the preparation is really key.
Yeah. Is there any limitation on the amount of PDT treatment somebody could have? Let's say they come in from one indication to another. It's not no
limit.
Yeah. So if they want it for like a licensed indication and then an off license,
that's fine, absolutely fine. There's no limit. I mean, the only thing that we have seen, and I alluded to that lady who, after probably 2 or 3 years of having PDT regularly to the lower limbs, she did develop a contact sensitivity, but otherwise there's no limit.
So finally, if somebody's, we've got, let's say our practitioners who, they may have the device or thinking about getting, the TriWave MD, but they're not doing PDT treatment, as a sort of a startup. And I'm sure it must vary from country to country. So sort of how would somebody get started? Qualifications. I know it's obviously it's into the dermatology, but
I mean, it's I think it's great to read around the European papers and the guidelines. So obviously do your sort of background reading. I think within the BAD standards, for the first time, as I say, 2018, it is documented that they recommend clinicians go through an initial training session. And I mean, that might just be an hour's training session like today. I mean, that might tick a box for your session we've delivered today, might tick a box for a lot of people. Then the update should be usually every 3 years. That's what the BAD is saying. So every 3 years you're updated. It says within the documents that will remain important in terms of competency sign off as well. So everyone's individual with that. Some people like to be observed and signed off as competent, but it is quite a straightforward, simple procedure. So probably a lot less complex than a lot of the other procedures that some clinics are undertaking.
Perfect. I think we had a little bit of a connection issue there. I don't know if it was bad on our side or not, but
Okay.
just to recap, in case we just want to sort of,
Yes.
if I just recap that. So if somebody's, obviously we've got our TriWave MD clients, you know, that maybe haven't done PDT before, but maybe thinking about introducing the service into their practice. So I know it can vary from country to country, but it, you know, is it, you know, maybe they need to be dermatology sort of level, but obviously we've got this course today.
Yeah, I think you know, important question, Louise. I think, you know, good background reading to PDT, looking at the European guidelines, looking at the BAD service standards as well. What they're recommending is that, you know, after your initial training, and I think today's webinar would be a tick box for going through sort of an overall training on red light PDT. Then updates every 3 years. Some clinicians are very open to people going in to shadow them and sign off clinical competencies. You know, some people are keen on that, some people aren't quite so keen on that. So I think in terms of, you know, initial training, get yourself going. You know, networking with other colleagues is great as well. Some of the pharmaceutical companies that produce the photosensitizers do give you a support package. So, you know, it may be that you choose who's going to support you in terms of ongoing education. That's very much part of my role in my independent role. So there is help out there. There are people that help to guide you and support you. But I think, you know, do the background reading, get yourself up and running. It is a straightforward procedure, and I think probably a lot less complicated than many of the procedures that people might be doing in clinical practice.
Yeah, when we look at the step-by-step guide, which was fantastic, it just simplified it and you know, what we should be doing.
Yeah.
But yeah, so just to recap, I think if somebody is, you know, in terms of the actual protocols and sort of the actual treatment, so this is going to be provided or should be provided by the suppliers of the photosensitizers.
Yeah, I would say so, Louise. Yeah.
And so just as a manufacturer, obviously we're of the light source, we're just, you know, we're providing the facility to the illumination and actually to activate the drug, but difficult for us to give a protocol because obviously that will be dependent on
the photosensitizer. No, and it, totally, that's my experience. So if I've purchased a new red light source to use in clinic, you know, yes, the manufacturer would support me through that, but in terms of the actual clinical procedure, I would go back to the pharma company that have manufactured the photosensitizing product and get my support from there. And there is help out there with the photosensitizers that we've mentioned today.
And I suppose, like you said, you know, there's the future's exciting. There's a lot more indications, there's a lot more application, and I think it's definitely an area of interest and a growing area of interest. So hopefully, that will incite more information.
Yeah.
Well, lots of questions, lots of information, lots to think about. It's been absolutely fantastic. So thank you so much, Paula, you know, for sharing your extensive experience with us. I hope to everyone who's watching it's been useful. If you have any questions on this subject, then you can either email them to us directly, info@dermaluxled.com. You can contact your local distributor, and then obviously we'll collate that information, and then, you know, we're very fortunate to have Paula on hand, and hopefully we can get back to you with any specific questions that you have. But thank you again, Paula. Thank you so much.
My pleasure.
All right.
I enjoyed it. Thank you.
All right. Thank you. Bye-bye.